Hi and welcome. Today we're going to talk about a disorder that affects millions of people worldwide. It's not just Monday morning, but it's actually iron deficiency anemia. If you want to learn the facts, then stay tuned and let's get started. All right, so we're going to start this with a question. What is the difference between ferric and ferrous iron? So when we say ferric, we imply Fe3 plus. And when we say ferrous, we imply Fe2 plus. So iron itself can enter the body in various forms. Probably you must have heard of non-heme iron. This sort of iron is mostly obtained from vegetables, and the predominant iron is in the ferric state, which is Fe3 plus. This sort of iron is poorly absorbed from the intestines. Now, in contrast, if we take a look at heme ions, you will see that the predominant iron there is in the ferrous state. And this sort of iron is vividly or properly absorbed from the intestines. So iron is very essential because it can act as a cofactor for many enzymes as well as proteins, including hemoglobin, right? And just as much as iron is very useful, don't forget it can also be very toxic because from biochemistry, you recall that iron can catalyze the formation of free radicals, and this can lead to oxidative stress. So, for the body to mitigate that risk, the body has very complex regulatory systems that ensures a safe absorption, transport, or utilization of iron in such a way that the potential toxicity is reduced. So we're going to take a look at iron absorption. So let's say we have an individual consumes iron in the state of ferric iron, right? That is non-heme iron. So we have a non-heme iron right here. This should be converted into the ferrous state, Fe2 plus, otherwise known as ferrous state. This is done with the help of ferric reductase enzyme, specifically the duodenal cytochrome B. Okay, now once we achieve ferrous iron, it goes through a certain gate which is known as divalent metal transport 1. Now, with the help of this gate, ferrous iron is able to get into the enterocyte. All right. Now, if we have another individual consume meat, which probably contains, say, a lot of the ferrous iron, that's going to be heme iron right here, then heme iron already has a channel through which it enters the cell. This is going to be called heme carrier proteins. So through these channels, heme iron is able to get into the enterocyte. It is then broken down into biliverdin and it is able to release the ferrous iron. So we have ferrous iron inside the cell. This sort of iron is now able to bind to apoferritin and it is stored as ferritin inside the cell. It can also be mobilized. It's important to understand that the ion within the cells are transported into the bloodstream, which is here, via these channels called ferroportin 1. Okay, it is a gate that is located on the basolateral membrane of the enterocyte. So on this basolateral part of the cell, we should have a ferrooxidase enzyme, which is called hephistin. This enzyme then converts the ferrous iron into ferric iron. As you can see, what happened inside the lumen of the intestines is the opposite that is occurring in the blood, because here we are oxidizing the ferrous iron into a ferric state. And we need a ferric state because, as you can see, there is transferrin there waiting to get saturated. Transferrin is waiting to transport this Fe3 plus or the ferric iron to say the bone marrow for erythropoiesis or to the tissues for its metabolic processes. So it's important. Now, again, something that we have to mention is hepcidin. Hepcidin is a protein that is produced in the liver and it regulates these channels called the ferroportin. Why is it important? Because we do not want iron to always come into the bloodstream if it is not necessary, because iron, as we said, can be very toxic. So hepcidin regulates by degrading. Okay, it causes degradation of these ferroportin gates, and by so doing, it is able to prevent excessive iron from entering the bloodstream. So the more hepcidin that you have, the more the destruction or the more degradation of these channels. So there will be less and there will be less iron coming into the bloodstream. Now, meanwhile, you can also see that there are macrophages right here. So these macrophages can also store some of the ions from the senescent or the old red blood cells through ingestion, phagocytosis. It is able to also break it down into biliverdin and also release the ferrous ion. So macrophages can also serve as a reserve pool for the iron. And hepcidin again also controls the regulation of the release of these iron from the macrophages as well. All right, so in iron deficiency anemia, the level of iron in the blood may be reduced. However, this is not the most sensitive test because there are patients who may actually have a low iron level in the blood, but the storage of iron may be normal. Again, since there is a deficiency, the level of iron in storage is also decreased. So the ferritin levels will be decreased, and this is a very good test, a very sensitive test in the identification of iron deficiency anemia. There are situations that can mask or make it a little bit difficult for ferritin to be used, and one example is malignancy or a liver disease or in inflammations. These disorders can actually lead to a high ferritin state because ferritin is an acute phase reactant. Okay, so let me give you a scenario. You have a patient with iron deficiency anemia, and then you expected that the ferritin levels would be decreased. However, it came as normal. Now, the reason why it turned out to be normal could be one of these disorders. Because of the acute phase reactant, it can actually move the low ferritin levels to normal, making you think that there is no iron deficiency, but there could in fact be iron deficiency. So let us take a look at transferrin, which is transporters made by the liver. So in case you have less iron in the blood, then there will be less iron saturating the transferrin transporter. Hence, transferrin saturation would also decrease. And then total iron binding capacity is increased. Why? The question you ask yourself is how much transferrin is the liver producing? Now, in iron deficiency anemia, the liver makes a lot of the transferrin to go and get the iron that is deficient. So the more transferrin that the liver makes would mean that there will be a total iron binding capacity also being more or being increased. Right, so in iron deficiency anemia, the liver responds to the low iron levels as well as the low ferritin levels by producing iron regulating protein 1. Now, this is done in an attempt to potentiate transferrin receptor expression. Now, this is the reason why the total iron binding capacity would also be expected to increase in iron deficiency anemia. This in turn reduces mitochondrial enzymatic activity. For example, aconitase enzyme's activity will decline. This would certainly lead to a low ATP production. It results in a compromise in the production of energy by the cells. So there will be poor hair as well as nail growth. In other words, there is an impaired biosynthesis in general. Typically, the red blood cells of iron deficiency anemia are microcytic hypochromic. So what does that mean? Let's say as a doctor, you ask for a complete blood count And you'll like to assess for the mean corpuscular volume, which actually implies size. Normally, this should be within the range of about 76 to about 100 femtoliters. Some books would also advocate for a minimal point of 80 femtoliters. So the patient with iron deficiency anemia will certainly have a smaller cell, a smaller red blood cell, so the MCV levels will decrease below 76. And we're going to call that microcytic because the cells are small, right? Further, you would also like to take a look at the mean corpuscular hemoglobin concentration. So here it also implies the color of the red blood cells. Normally this should be around say 34, plus or minus 2. So the patient with iron deficiency anemia may probably have something around less than 32. Okay, when you have something like that, we would also call it hypochromic, meaning that the cells have a low mean corpuscular hemoglobin concentration. So the classic thing you see in iron deficiency is a microcytic hypochromic. Now these cells, when it is chronic, actually have an impaired oxygen delivery to the tissues, right? This results in a tissue hypoxia if it is a chronic disorder. This can stimulate the bone marrow to produce more red blood cells actually under pressure. And so the bone marrow releases a diverse population of cells into the circulation. This phenomenon is characterized as anisocytosis, different sizes that are actually microcytic. So there is microcytic cells, but there is a range of different small red blood cells. You see this red blood cell, see that red blood cell, different sized red blood cells. And you can see that the red blood cell distribution is actually widened or elevated. Okay, and when you have these different sizes, we call it anisocytosis. When the bone marrow is producing red blood cells of different shapes, if it is shapes, then we will call it poikilocytosis. Now, we can also take a look at the red blood cell distribution width, as I said, and we are looking at a standard deviation of the mean corpuscular volume, which is actually increased because there is diverse sizes, smaller sizes, microcytic cells. So this equation will lead to an elevated red blood cell distribution width. So in summary, the varied morphology of the red blood cell in iron deficiency anemia is a reflection of the bone marrow's attempt to compensate for the impaired oxygen carrying capacity, which results in a spectrum of red blood cell sizes and shapes. Clinical manifestations. Iron deficiency anemia can manifest in various ways with cluster of symptoms as well as signs, and this may include easy fatigability, shortness of breath on exertion, tachycardia, palpitations, or being pale in the skin as well as the mucous membranes. Again, chronic iron deficiency anemia can lead to skin and mucosal changes such as smooth tongue, brittle nails, and lesions may also be found on the mouth as well as the lips. In short, there is also something called koilonychia, which is spooning of the nails. So patients with chronic iron deficiency anemia may have nails that looks somehow like this. Okay, and so what you see is there is spooning. There is that shape of the nails, and this is known as koilonychia. In some cases, it may also present with unusual cravings known as pica for different substances like ice, starch, clay, lettuce. Advanced stages of iron deficiency anemia can be associated with Plummer-Vinson syndrome, which is characterized by inflammation of the tongue, that is glossitis, dysphagia, and esophageal webs. Diagnosis. So the iron levels will be decreased. Ferritin levels are very important and often needed for confirmation. It would also be decreased. Total iron binding capacity increases, and it's clear transferrin also increases. Transferrin saturation is low because of the low iron levels. The mean corpuscular volume is decreased, and so we have a microcytic cell. The mean corpuscular hemoglobin concentration is also decreased, so we have a hypochromic cells. The red blood cell distribution width is increased. Now, this is due to the anisocytosis, and poikilocytosis. There may also be an elevated platelet levels, but this is often reactive. All right, so it's essential to consider a comprehensive gastrointestinal tract workup in the evaluation of iron deficiency anemia, including a bidirectional endoscopy, that is, an upper GI endoscopy as well as a colonoscopy. So, you must also consider red flag signs such as unintended weight loss, heme positive stools, dysphagia, or anemia. In fact, if you have, say, a 60-year-old patient who has iron deficiency anemia, then you'll probably like to do a colonoscopy for this patient. Moreover, H. pylori, Helicobacter pylori, is been also linked to iron deficiency anemia, and a thorough evaluation may require, say, a urea breath test, stool antigen test, or serology. One important thing to note is that sometimes if you treat H. pylori, the iron deficiency anemia can even get better. Additionally, celiac disease is another important consideration as it can also be associated with iron deficiency anemia. And do well to consider nutritional deficits, and also importantly, frequent blood donations can also cause iron deficiency anemia. Treatment. So it is important to identify the root cause of iron deficiency and initiate appropriate treatment. In most cases, oral iron supplementation with ferrous sulfate, ferrous gluconate, or ferrous fumarate is effective in replenishing the iron stores. Notably, ferrous fumarate and ferrous gluconate are often well tolerated. In instances where absorption is impaired, or there is an intolerance to oral iron, or the demand for iron cannot be met with oral therapy, then parenteral iron may be necessary to ensure adequate replenishment of iron. Blood transfusion should be judiciously reserved for severe acute anemia with HB levels less than 7 gram per deciliter, as well as in cases where acute anemia coexists with conditions such as congestive heart failure, chronic kidney disease. In these situations, it is essential to strive to restore the HB levels, if it is very low, to a safe range such as 6 to 8 gram per deciliter. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.